हॅलो. हे चेक. हॅलो.
चालू केलं, माईक चालू केलं मी आता.
हॅलो. चेक चेक टेस्ट.
A very good morning to all of you. On behalf of Nobel Hospital, I welcome you all. Without wasting time, we will just start your conference today. I'll just welcome Dr. Archana ma'am and to take the stage over. Thank you.
Yes. Good morning, everyone. Chairpersons, hosts, and everyone in the audience. My first talk, I'm the opening batsman, and I'm going to be talking about beyond insulin in type 1 diabetes, meaning not treatment modality, but what does type 1 diabetes need beyond just insulin when we talk about care. This is my CV, but as you can see, my main work is in type 1 diabetes. I run an NGO called UDAN in Chhatrapati Sambhaji Nagar, where we care for children in the rural most areas. So my passion is finding quality care, standard of care, translated into the lowest resource setting of literacy and finances. So we're going to talk about what do we want in type 1 diabetes care. For most physicians, except if we talk about pediatric endocrinologists and endocrinologists, for most physicians for a very long time, it was only about insulin because there was not much available. But now, when we think about it, the care, for example, children are growing up, they're adults, they're no longer going to just the pediatricians. Now you have newly diagnosed people at a very young age, which can be a very confusing spectrum, but so many are type 1. So ultimate dream would be to have a cure, but if until we had a cure, what would it look like? So it would look like a child. This is Nick Jonas, Priyanka Chopra's husband. He was 12 years old when he had type 1 diabetes. He's a rock star. He travels all over the world. He's a big guy. And why shouldn't every other child, every child in our country have the same kind of life? And that is what we are talking about. And that becomes our responsibility as clinicians to be able to guide them to have a similar life, which is clinical, but which is more than clinical. So, a full life, safe, supported, and stigma free. These are my girls when they come for a summer camp. These are girls from small villages who were 2 years old, 3 years old when they had type 1 diabetes. And why should they be deprived? Because I'm sure they have the potential to become a rock star one day. And that is what type 1 care would look like. I'm going to start the day. I know it's a bright morning, but with a little sad story just to tell you why we are talking about beyond insulin. This is a little girl. That's a 2017 photo. You can see the circle. She was a young girl with me then. And then she grew up, and now you can see in the last photograph, she's a mother with her own daughter. But this girl was given kerosene by her parents and locked up in a room with a matchbox and told that, why don't you end our misery? Because it was not just the cost of insulin, monitoring, but the stigma. The family was being discarded, school there was discrimination, neighbors were not talking to them. Her other sister was not getting married because the younger sister had type 1 diabetes. So it's way more than just having diabetes and giving the right dose of insulin. So when you see a person with type 1 diabetes, it is a psychosocial, emotional ecosystem that needs to be created beyond the insulin dose. Of course, she grew up to be a very strong woman. She's a teacher today, but she again faced stigma when she got married and she finally left her husband. She's a single mother running her own business, a Zilla Parishad school teacher, and leading a great life. HbA1c never crosses 7, but it is this entire 360 degrees ecosystem that I'm talking about. So if we take away the emotion part for just now, but I don't think we can, because that becomes the core which makes them want to do things. So it's early diagnosis, then it's structured diabetes education, physiological insulin therapy, self blood glucose monitoring, and follow up. Very quickly, because we do not have time, one more and very important, if even one person today takes this message home, that all this cannot be done without peer group support. The biggest stigma for a person living with type 1 diabetes is that I don't know anyone else with type 1 diabetes. And the moment they meet someone else of their age or older who is doing well, and that entire thing melts. And the dose that you have prescribed, the care you have prescribed, suddenly becomes real because they are willing to do it. So, early diagnosis, now we know the stages of type 1 diabetes. We still know that people in India, especially, are still detected with DKA at diagnosis. Every DKA makes the mental acuity, the cognitive, the lifespan, everything deteriorates. So, if we could detect people with type 1 diabetes early enough, it would be great. Of course, now we have some approved tests and we have a drug, but we don't know how appropriate it would be for India. So even if that doesn't happen, a reality check would be education. Yet I get every child in DK because the local doctor did not know that children can get type 1 diabetes. And these symptoms are of diabetes in a child. A child needs to be screened, child needs to be put on insulin. So if we could all in our areas just spread the message, train doctors, train paraclinical staff, create a lot of noise, it would be lives saved. You know that currently we have around 10 lakh surviving people with type 1 diabetes, and in last 15 years we lost 10 lakh just because they were not detected and given insulin and strips. So it's not just insulin, but of course we can't do without it. So once we have detected, there is no step forward without education. This is not do you understand, do you not understand? It's survival. If you don't know the insulin technique, if you don't know how to rotate, you have huge lipohypertrophies. If you don't know how to monitor, you don't know how to carb count, you don't know how to adjust your own dose, then what's the point of giving a prescription of insulin and sending the child away? They just come back in the next hypo or next decay and again get admitted. That life is worse than not being, living at all. So even if one is giving free treatment, it is structured diabetes education, which is the biggest cornerstone. I'm not going to go into details, but it changes their life immensely. This is Uran snapshot. We have almost negligible hospitalization due to diabetes anymore. And I'm talking about absolutely low literacy villagers working as farm workers. Just because, so in a child in a village, in a hut, in Marathwada will tell you that मला काकडी दे, मला अंडी दे, कारण माझ्या ताटात प्रोटीन नाही आहे, फायबर नाही आहे. कार्ब काउंट करून तो चाइल्ड, एक डेली वर्कर की बच्ची can inject her right dose. If we can empower them with this, this is very much possible. That changes lives. It's not just an insulin prescription. I'm not going to go into details, but for all of you who think it's difficult, even if you're handing out free insulin out of charity to a person, it's not okay to give just insulin. Education is a very important part. There are courses today in the country that one can take. ISPE conducts courses, various institutions conducts. So either you get a team, or you train your team, or you create your own team. What I created is called Mighty Moms. We got a team of mothers of children with type 1 diabetes who are doing well. We created a curriculum, we trained them. Now 30 mothers of children with type 1 diabetes are called D coaches, and they take care of the education of everyone else, because where will I get 30 educators for 1500 kids that I support currently? So if you don't have a team, it's okay, create your own, train your team, or send to the nearest sister that has a team. It's not okay to be without an education team when you are treating a chronic disease, especially something like type 1 diabetes. So just do it as I say. We talk about insulin. Unfortunately, I still see premix prescriptions, so many of them in type 1 diabetes, because they were not ready, they were not willing. That's not a choice. Giving premix is, for a child, is almost criminal today. It's absolutely non-physiological. And if the first doctor gives a premix, by the time they come to us or somebody else, it's so difficult to convince them from 2 versus 4. So the first time, it's not about money. It can be regular and NPH combined and given as a basal bolus. But basal bolus is the only physiological management, because these children are growing. You cannot give them a non-physiological variable blood sugar levels, which are not visible because they're not monitoring enough. There's no CGMS. You don't know every night there's a hypoglycemia. Every evening there's a hypo and a hyper, which is not being documented. And we think child is alive. But they're only alive. Where did all the adults go? Now we have adults with type 1 diabetes with 20 years, 25 years of diabetes. Where are the earlier ones? Why don't we have our age group in this hall? Why don't we have 10 people, 10 doctors who are living with type 1 diabetes? Because they were all on premix and no monitoring. And the span used to be 40, 50, and that's not okay. Again, so MDI at a baseline, MDI with monitoring, with carbohydrate education, counting education. It just empowers them. So just MDI is not enough, just monitoring is not enough, and just education. So just three together is such a power, it's their right, and it is something we should know. I will not ask, but I'm sure if we introspect, most of us will not be knowing carb counting. I did not. I learned it because I did not, and I learn it every single day. But if I'm going to treat a person with type 1 diabetes, my bare minimum care is going to be MDI monitoring and carbohydrate counting education so they can do their self-dose adjustment. So currently, we are in a very, very bad shape. But if we give one strip extra or a child tested one more time, it would be another 4 hours of their life. So that's how it works. So insulin therapy without monitoring is totally unacceptable. When you talk about insulin therapy, talk about monitoring in the same breath. And both have to be physiological. It has to be basal bolus, has to be physiological, has to be with adequate monitoring. And then you've taken insulin, you have checked, and what do you do with it? How do you take the dose? And hence, as I talked about, the structured diabetes education. So we know these phases of HbA1c. So many times people on premix would come and say, my HbA1c is 6.5. But what does it mean? It could mean the time in range is pretty bad. There's so many hypoglycemias. Look at this graph of this is a child in a village, an 18-year-old boy who's working part-time, studying part-time, just because he empowered himself. And his mother is a laborer in a field. Look at his time in range. Where does this come from? Because he knows what to do with the numbers. He knows that if he is having pani puri, how much insulin to take. The pani puri wala near my center knows now how to bolus because so many kids come there, check their sugar, count that pani. Now he tells them already that 5 puris now have 1 carb. You can take your dose accordingly. That is how normalization of type 1 care can happen. So reality check, we do not monitor enough. We have amazing CGMSs. Of course, they are expensive, but gradually, hopefully, the prices will come down. Could we make it even better? Yes. I believe in a top-bottom approach. So I'll just go through this because I have of lack of time, but we know what a hybrid closed loop pump is. Now, this is something that has changed. It's become a game changer. And sometimes we think it's very expensive, but think what it does. What it does is gives you amazing time in range. It takes away the entire burden because it is taking all the decision with AI. Here the blood sugar is being checked, here the insulin is being injected, and it is talking through an AI and setting the dose, not letting the blood sugars drop, neither go high. Imagine a mother can sleep in night without worrying that my child is going to now be in hypoglycemia, checking 100 times, adjusting the dose. It just changes the quality of life. Yes, it is expensive, but this is what I like to say, that we should think of the best we can offer. Top-bottom approach, not the minimum up. First, tell there is an insulin pump available, which is closed hybrid loop, and that is the best you can. You never know, somebody might source it from somewhere. Next, of course, what would I do if it was my own child? Then it would be CGMS and MDI. With education, then it would be with the peer support group. And then it would be SMBG, SMBG, MDI, and education. Would you settle for less? No, we shouldn't. For anyone, MDI, SMBG, and education is the bare minimum care that we can give, not the premix prescription or just an insulin prescription that we talk about. And last but not least, peer group. So there's a beautiful slogan they have, nothing about us without us. So if we include them in this journey, it just motivates, it just makes them do all the things that you wrote on paper. Because we, as clinicians, may not have time to talk, motivate, tell so much. But when they meet their people, then when they speak, everyone listens. This is last week. These are 31 rural advocates. It's a project called TARA that we launched last week. It's called Type 1 Diabetes Advocacy for Rural Areas. These are 31 young men and women from chote talukas of Marathwada, who are now working in their taluka, going to pharmacists, doctors, schools, driving a change, creating early detection drives, and removing stigma with care of type 1 diabetes. So far, all the doctors they met, they said, we didn't have a clue that what is this. So it's like people didn't know anything. Doctors didn't know about 100 IU syringes, 40 IU syringes. So that's where grassroots care levels. But suppose I had gone, would they have listened? Probably not. But when a boy or a girl stands up and says, I am from this village, I have lived with this for last 20 years, listen to me, they listen. So please include the peer group in your management of type 1 diabetes. We have a policy vacuum. I will not go into that. But top-down approach is my last message, that try to offer the best, next best, and next best. And let your last offering not be a compromised offering, no matter how low resource setting is there. Dr. Sanjay Agarwal from RSSDI is here. RSSDI runs such a big support system for people who are with type 1 diabetes. Just reach out. Just reach out to the nearest place where they can get support, empower them with education, and make sure this happens. Thank you. This is Tie Up. Tie Up is the only national program for type 1 diabetes where doctors, educators, and people with type 1 diabetes come together. So I invite you to Kanpur in December. With that, I finish. Thank you so much.
Thank you, ma'am. Thank you so much for your informative talk. Any questions from audience?
Good morning, ma'am.
Good morning.
So that was a wonderful talk, and I think we should appreciate what all work you are doing for type 1 diabetic patients. I just have two quick questions. First about, so I recently saw one child who is a cousin of type 1 diabetic, and he's in IGT range. Basically, fasting is IGT, or maybe fasting just the range. He came with HbA1c around 5.8. And what we know about now, it's in a preclinical stage at this moment. Family is worried because they have seen the cousin is suffering last 2 years. And we know now that teplizumab is now approved last 2 years back, but it is still availability is a big task in India. So is it, I mean, worth because the cost, looking at the cost and how to get, do you have any experience about that? Because you see a lot of patients.
Yes.
Second question about prevalence of celiac disease, how commonly you see in your center in
Yes.
type 1 diabetes? And last one, so in puberty, I see few patients in adolescent age group. It's always become very challenging to control the blood sugar when they hit puberty. So do you feel, what strategies do you apply at that time in peripubertal children in type 1 diabetes? Because it's always difficult to get the A1C in control.
Absolutely. So I think all three are absolutely relevant questions. I'll answer the easiest one first, and that is a celiac. So in our center, out of 1,500, we have 64 who are positive for celiac. We do screen every year, then we get their biopsies done. So in Maharashtra, the incidence is there. So the prevalence is, I don't know what percent we would take. So 60 out of 1,500 is what I have right now in our center. Adolescence is a huge challenge physiologically as well as psychosocially. So what we do is we have an adolescent girl group and a boy group. We have a hand-holding support system where we have WhatsApp groups, which is specially designed for them, so that we can interact with them. There are lots of challenges. It's not just the blood sugar level, it's also the cycle time. And so we have special training programs telling them, yes, your sugar is going to rise. What really happens is that they get a lot of flack from their family saying, why is your sugar high? So when we explain to the family that this is physiological, this is going to happen, this is going to happen at certain times. So they put red dots in their diary so they know when is their menstruation time, and not just the daily cycle, but also otherwise. And so we have a special training program that helps. Still, they are high. I agree with that. But carb counting has really helped. That is another thing. And last, as you said about the prevention, it's a dilemma. I do have such cases as well. So far, we have told them this is there, this is on the horizon, this is available. All we can do is give them good counseling and education, but it creates a lot of fear, waiting when is going to manifest. So they're all monitoring, have been counseled, handheld, but currently we have not really given them a drug for prevention. Thank you so much.
Thank you, ma'am. I'll just request Dr. Khare sir to start his talk. Over to you, sir.
It's not. Hi, good morning, everybody. So first, a big compliment to Rima and Aparna and everybody over here, because I've had a lot of these conferences and I know what headache and heartache it can be. Grand show so far, you're doing so well. So friends, we doctors are supposed to be lousy in maths, aren't we? We always are in our own ivory towers and we feel that 1 and 1 is 2 and 1 plus 1 plus 1 is 3. We cannot be more dumber than that, because in the topic which I'm going to talk about, you'll realize that especially when the topics are like obesity and diabetes and OSA, 1 plus 1 plus 1 is not 3, it can be straight away 3 lakhs. Add to it the sheer ignorance of a lot of us. We don't really think of OSA, and then what happens is straight away in crows, as my following slide we showed. This patient and my next topic, both are based on actual real life patients, and it's straight from the heart. So this guy, poor guy, he was a chartered accountant in a very reputed firm, and his owner was my patient, and he says, "Doc, please look after him. He had a very promising life. He was doing well, and then now he's going to the seed. He just doesn't seem to be functioning. As a chartered accountant, he had a promising career. Right now, he's just going downhill. Constant fatigue, weakness. He feels, I just don't feel like doing anything. He's a couch potato. And even after he gets up in the morning, he comes up dressing like a slob. It's bad for me. It's bad for my company's reputation. Very poor productivity. In spite of being such a good worker, I've had to lay him off. He's on a sabbatical at this point of time. His wife took him to a psychiatrist who prescribed him sertraline and clonazepam, which made it worse. And actually, when he came to me, his whole complexion was so totally different. And that was a challenge of this patient. He was obviously obese with a BMI of 34. Neck circumference was a whopping 46. And you can all imagine what that implies. There was no nasal polyp or something, but his Malampati score was way high. Now we all know that Malampati, invented or described by Dr. Malampati, an Indian anesthesiologist, tells us about the amount of crowding in the upper airway system. And this guy had a class 4 straight away. So I could barely see the heart palate. I asked a few questions, and sure enough, I struck gold. The wife says that she can't sleep a wink because of this guy snoring. In fact, she was sleeping in the other bedroom. And she did say that even when this guy drove, she had to constantly nudge him. Are you out? Are you out? And at times, he almost crashed a couple of times. There were times when he saw the television and he's dozed off. While reading the newspapers, he was dozing off. And of course, stop, bang questionnaire, which everybody knows about, was irrelevant in him because it was way high. So these are something which all of us ought to be doing, and something which is very easily done. Because of the rising epidemic of obesity, I think we should be doing this. Otherwise, we are failing ourselves, we are failing the science, and we are failing our patients. So straightforward, stop bang questionnaire. Was there reduced alertness, cognition, mental sharpness? Oh my God, yes. So he was really bad, his memory, alertness, everything was down. Other relevant parameters, uncontrolled diabetes, TGs were 455, obesity, uric acid was 6.9. Now, in Indian, Asian people, a high uricemia is itself supposed to be a very bad metabolic parameter. Urine was showing pus cells, which was surprising because for a male patient, I would not really expect pus cells over here. Hemoglobin was 9.9, which made it worse for me because his HbA1c was obviously under-invoiced because of the baseline hemoglobin being low. GFR was 56%, liver enzymes are high, obviously fatty liver, TSH was borderline. Echo was showing a preserved fraction, but with impaired relaxation, B12 and B3 were pathetically low. So the first thing I did was I leveled with a couple. I told them, this is what you have. You have a condition called obstructive sleep apnea. Most important for your life is Mr. Oxygen, and you're deprived of it. Because every time you're vertical, the oropharyngeal pathway is clear, and every time you lie down reclining, the entire palatopharyngeal muscles are collapsing back on your windpipe, causing obstruction. Principles of physics, you pass air through a stiff resistance, you're going to get a sound. That snoring was basically a sound. It was your body's cry.